Hi, my name is Sydney Gendron, and this is my Bcit 7150 breastfeeding video assignment on breast engorgement and twins. To address the breastfeeding challenge of engorgement in twins, I will be using the situated clinical decision-making framework, which includes knowledge, cues, judgment, decisions, and evaluation of outcomes. First, what is engorgement? Engorgement is the overfilling of breasts with milk, which can be painful. This commonly occurs around 2 to 5 days after delivery when the woman's milk starts to come in. The main cause of engorgement is an imbalance between supply and demand of breast milk. The supply occurs when the breasts fill with milk, and the demand relates to the adequate emptying of breasts, which can occur in multiple ways, which we will discuss later in this presentation. The pathophysiology behind engorgement is laid out in the diagram below. After a woman gives birth, progesterone and estrogen levels drop. This is caused by the separation of the placenta from the uterus, which is the main source of these hormones during pregnancy. Once the placenta is born, prolactin is released from the anterior pituitary gland, which is responsible for synthesis and secretion of breast milk. As the body is creating milk, the woman's breasts may feel fuller, can be swollen, warm to touch, and uncomfortable, which is caused by milk, blood flow, and edema that overdistends the alveoli and milk ducts, which leads to breast engorgement. The causes behind engorgement vary. As mentioned earlier, breast engorgement occurs when there is a mismatch between supply and demand. This may occur when your milk first comes in, waiting too long to begin breastfeeding, when your regular breastfeeding routine is interrupted, not feeding frequently enough or inadequately emptying the breasts, if you suddenly stop breastfeeding, when your baby starts breastfeeding less than usual, for example, when increasing solids, or if your milk ducts become obstructed. Why is there an increased challenge with breastfeeding twins and engorgement? Well, when breastfeeding twins, a main concern for mothers is whether or not they have the capacity to produce milk for 2 babies. Factors that influence twin feeding and engorgement include prematurity, leading to the inability to effectively feed at the breast. As we know, approximately 50% of twins are born prematurely, and with that comes feeding issues of a weak suck, inability to suckle for an adequate amount of time, and fatigue from latching and suckling. In relation to prematurity is the possibility of separation of mother and one or both babies due to the need for admission to the NICU. This impacts mother-baby bonding, ability to feed the baby at the breast, and emotional stress, which can take a toll on the breastfeeding experience. Twins also have an increased need for supplementation. This can be caused due to their smaller size, weight loss, and the ability to effectively breastfeed. Lastly, there is an increased challenge with positioning and latching 2 babies at the breast. To decrease the length of feeds, mother may want to tandem feed, which can prove to be challenging in the beginning. When breastfeeding, we want to ensure a correct latch and maintenance of latch for adequate feeding times. If either or both of these are not well established, engorgement is a potential consequence. Now on to cues relating to the signs and symptoms of engorgement. Engorgement may be physiological and occurs naturally as a process of lactogenesis, or it may be pathological, relating to the ineffective or infrequent removal of breast milk. Physiologic engorgement results in breasts feeling heavy and soft without symptoms of pain. For this purpose of this assignment, we will focus on pathological engorgement, as this creates more problems for the breastfeeding mothers. Pathologic engorgement results in swollen, firm, and painful to touch breasts. Breasts may be hard, shiny, warm, and lumpy to touch. Overdistensions of the breast may cause flattened nipples and firm areola, and engorgement can be associated with a fever of 38 degrees and above. Subsequent swelling of lymph nodes may occur in the armpits due to backup of lymph, blood, and breast milk. All of this will result in a difficulty to latch the baby. And engorgement is diagnosed based on symptoms alone. No tests or examinations are required. Engorgement has effects on the mother, the newborns, and the feeding relationship. The main effects on the mother include difficulty positioning and latching the babies, breast and nipple soreness, and fear of pain with latching, as well as anxiety related to the fear of the pain when baby goes to breast. Newborn effects are that the babies may not have an effective suck due to their prematurity, or they may not receive enough breast milk due to their inability to suck, which leads to supplementation and potential for decreased breastfeeding rates. The effects on the feeding relationship are mainly focused on the maternal psyche. This includes decreased desire to continue breastfeeding or the lack of confidence in her ability to breastfeed her babies. Although engorgement presents a challenge for mother, baby, and the feeding relationship, it is important to focus on the 3 main priorities of breastfeeding. First, feed the baby. As previously stated, when a woman becomes engorged, her milk ducts are overdistended, which causes pain and milk stasis. The supply of milk is present, but the effectiveness of the baby feeding and getting enough milk is inhibited. In addition, when feeding twins, mothers require an even greater milk supply. If the babies are unable to obtain enough milk, the mothers can pump and collect her breast milk to give an alternative manner, or supplementation may be required. Priority 2 is to empty the breasts. We have a few options here. Most efficient is breastfeeding, but this may be challenging due to engorgement. So alternate options are for the mother to hand express or use a breast pump to empty the breasts. Lastly, we want to support the dyad. So in a situation with twins and engorgement, I would encourage the woman to first pump to relieve the pressure on her breasts and soften them for the babies to latch. Next, I would want to support the woman with latching her babies. This may occur one at a time or in a tandem feeding style. Since the babies may not be able to effectively suck and empty the breasts for various reasons, I would encourage the mother to pump again after feeds if her breasts remain heavy. If they are nice and soft and she is comfortable, pumping will not do any good and may perpetuate engorgement. Now that we have a plan to support our breastfeeding dyad of twins with engorgement, we will look at the prevention of engorgement. There are multiple ways to match the supply and demand between breast milk and baby. This includes initiating breastfeeding soon after birth, breastfeeding your baby when they show hunger cues, aiming for a minimum of 8 feeds in 24 hours, ensuring a proper latch and effective suckling pattern to empty the breast, letting your baby finish nursing on one side before switching to the other. You want to make sure you're emptying your breast at each feeding, but if you need to skip a feed or unable to breastfeed your babies, ensures that you use alternate measures to empty your breast regularly. Research has shown that avoiding the introduction of bottle or artificial nipples can help prevent engorgement, as babies may become accustomed to alternate sucking patterns and may not take to the breast as well. Treatment of engorgement is focused on maternal comfort and effective emptying of breasts. A mother may choose to use warm compresses or take a brief warm shower prior to feeds to encourage a letdown of milk. It is good to note that using heat can increase swelling if used for long periods of time, so it is recommended to use heat for less than 5 minutes. In contrast, after feeds, women may find comfort from a cool compress. Cool compresses help to decrease the swelling that occurs with engorgement. Gentle massage and compression can help empty the breasts and can be done before, during, and after feeds to ensure relief of pressure. If pain is persistent and very uncomfortable, women may use ibuprofen to reduce pain and inflammation, as it is safe for breastfeeding mothers. If breastfeeding is unable to occur, a pump or hand expression may be used. We don't want to overstimulate the breasts, so once the woman experiences relief, we will discontinue using those methods. If engorgement is severe and is causing a woman's nipples to invert, reverse pressure, which is pressure applied to the areola on the outside of the nipple, may be effective in everting nipples and relieving nipple soreness. To ensure that breasts are being properly emptied, we want to ensure a correct latch. And lastly, there has been some research done around cabbage leaves and the relievement of engorgement, but caution with cabbage leaves, as they have been also shown to decrease milk production if used for extended periods of time. In terms of making sure that women are well supported, we want to make sure they are connected. They may benefit from connecting with a lactation consultant in hospital or in the community. They may want to make a plan to have family support for the first while when adjusting to life with twins and the breastfeeding demands. We want to ensure discharge planning is done effectively for a smooth transition from hospital to home. This includes the creation of a good feeding plan with the family, ensuring the babies are healthy enough to go home and the parents feel ready to go home. We want to make sure families don't feel alone when they are home, so connecting them with community resources is also very important. Breastfeeding groups or multiple groups may benefit the woman. Connecting them with the community health center and ensuring a visit from the community health nurse would be beneficial for these parents, as well as making sure that they are aware of groups such as the Lesh League and Vancouver Breastfeeding Centre for when they feel they may need some extra support in the community with breastfeeding. Lastly is the evaluation of outcomes, which we will refer back to the 3 main priorities. 1. Feed the babies. Are these babies properly latched and transferring milk? Are the babies gaining weight appropriately? If not, are these babies needing supplementation, and are we choosing the best supplementation for these babies? 2. Empty the breasts. Is the mother relieved from nipple and breast pain, which is caused by engorgement? Or are there any persistent signs of engorgement that is paining the woman? Is the woman using hand expression or pumping or reverse pressure? And what interventions work best for her and her baby? Lastly, support the dyad. Is there a well-established breastfeeding plan? Is the breastfeeding relationship fostered with the interventions that we have provided for engorgement and twins? Overall, the care of the woman with breast engorgement and twins is complex. Our main goal is to focus on the 3 priorities. This is done by educating the woman and supporting her with tools to enact these 3 goals. Thank you for listening to my presentation of breast engorgement and twins. I hope you find this helpful in your nursing practice to support mothers and babies in their journey through breastfeeding.